Death, dying, and bereavement. 25% of people die suddenly within hours of the first symptoms, and the greatest majority of these are due to heart attacks. The latter are painful as the heart is deprived of oxygen, giving crushing sensations. 75% of people have more drawn-out deaths. Congestive heart failure involves a scarred heart muscle that cannot pump oxygenated blood efficiently. With reduced blood pressure, fluid collects in the lungs. Bacteria go wild once inhaled and circulate to inflict harm on other organs. Cancer is also long and drawn out. It spreads to other organs via the bloodstream and inflicts severe depression onto 1/3 of its victims. The depression should be treated to enhance the quality of life remaining, to lessen pain, and to boost the immune system. 20% of people have the luxury of dying quietly and gently, some with drugs to ease pain. In the hours or days preceding death, a dying person will move and talk less and show little interest in eating or drinking. Due to drops in temperature, blood pressure, and circulation, the dying person's skin changes to a grayish color, and the hands and feet are cold. When death is imminent, the dying person experiences 3 phases: agonal phase, clinical death, and mortality. In the agonal phase, there are gasps and muscle spasms. In the clinical death phase, the patient can be revived, but has had stoppage of breathing and heartbeat. In the mortality phase, the person enters permanent death. Irreversible death in the brain, including the brainstem, has occurred. Anxiety about death peaks. In Elizabeth Kubler-Ross's 1960s study, she found 5 distinct stages of dying and bereavement, the process of grieving for dying loved ones. These 5 stages are denial, anger, bargaining, depression, and acceptance. In denial, a dying or bereaved person tries to escape the terminal diagnosis by pretending it does not exist. Medical personnel should be sensitive but should not distort the truth and prolong denial. In anger, the dying or bereaved person lashes out because of the unfairness of life. Relatives, friends, and medical personnel need to be patient and not take things personally. In bargaining, the dying or bereaved person tries to strike a deal with God for more time. In depression, the dying or bereaved person sinks into hopelessness. In acceptance, the dying or bereaved person feels peace towards the end. Other researchers have found that grieving and dying is an individual process, much like variations with living, and contend that there is not a predictable sequence of stages. Kubler-Ross's stages should instead be considered as coping strategies when trauma threatens. People cope with dying similarly to the way they coped with the stresses involved in living. The same bad news of impending death is received and reacted to differently by different people. Dying can be considered as imprisonment, as a reason to live to the max, as part of traveling through life, as something to avoid thinking about by distracting self. The concept of hope can evolve from hope of a cure to hope for a delay in death and prolonging of life to hope for a pain-free, peaceful death. Besides individual personality, besides coping styles used previously, besides levels of optimism or pessimism, culture and religion play a big role in how a dying person adjusts to death. Dying is as multidimensional and multidirectional as any other lifespan development. If given a choice, 80 to 90% of people would say they prefer to die at home, but only 20% actually do die at home. Oftentimes, the level of care needed at the end cannot be handled at home. Death due to a sudden emergency necessitating hospital treatment will not occur at home either. Hospital and medical settings are impersonal and infringe on privacy. Home settings are more intimate, but demand more from family members than what they may be able to give. Hospice is a middle ground approach that attempts to capture the best of both the hospital and the home when dying is imminent. Hospice does not try to prolong life, but to enhance the quality of what is left of it. It eases suffering by giving palliative care to manage symptoms. Hospice provides pain control, comfort, and coordination of services of all those responsible for the care of the patient: nurse, doctor, pharmacist, minister, family members, nurse aide, social worker. Patients die at home, and hospice continues to check on the bereaved family. To reduce suffering and distress of dying patients, music therapy has been shown to be effective palliative care. Hearing is the sense that is the last to go, so a dying patient can respond with less anxiety, pain, and labored breathing. For those left behind, a dual process model of coping with loss goes back and forth from painful mourning to tending to the practical changes in life brought on by the death. So the bereaved person shifts from emotional pain to meaningful actions and back again and again. The type of losses judged to be the most difficult are the loss of a child by a parent and the loss of a parent or a sibling by a child. If several deaths happen at once or come close together, the grieving is more intense. Grief-stricken people should be gentle with themselves and give themselves permission and time to mourn. Accept the graciousness of others who want and need to help with a meal, or to watch the children, or to listen. There is no road map, nor any one most correct way to recover. There is no definitive timeline that says a certain amount of grief is too little or too much. Bereavement is an individual experience and tailored for the person. Be prepared for an onslaught of varying emotions that come and go. Keep the memory of the deceased loved one near with pictures and stories retold. Some families release balloons on special occasions to remember the departed. Some find comfort with religious rituals. Prayer helps others. Writing is the best therapy and the cheapest. When ready, set short-term goals which reestablish life after the loss. Go to a movie, for a ride, for a walk in the park. Share a cup of coffee or an ice cream cone. Well-meaning folks who are at a loss for words would do better to say nothing and just lend a shoulder to cry on or an ear to listen. Quiet hugs and reassurances of availability mean more than the right words, especially since there are none. Some of the no-nos are, at least the baby died before you grew to love him or her. You can fall in love again. It is God's will. God never sends more than you can handle. Beware of these no-nos, and remember, sometimes a shoulder to cry on and an ear to listen, these are what are most needed.